person. I don't think I certainly know you by reputation, and for you being not just only a national figure and such a great mentor to so many people in your own areas, but to our very own Doctors Erin Mangold and Colin Costello. So this is a chance for me, before you start this talk, to thank you for your willingness to have a relationship at a distance with our folks and with this department, and to thank you for presenting today. Dr. Leachman, as she mentioned herself just a little bit ago, trained at Yale. My only connection to Yale is I was on the ABD with Jean Bologna for a long time. So Jean and I shared many moments together over 7 of our 9 years together on the ABD. She was at Utah for a while. Now she's been at Oregon, where I've had some recent discussions with a certain Dr. Wesley Yu, I believe is with you now, is he not? About melanoma and Mo's for melanoma. We've had some interesting discussions about that. And more, I don't want to go on, but to say that Dr. Leachman's got a national reputation. She's interested in melanoma and cancer prevention. She's got some interest in HPV and its relationship to squamous cell carcinoma at Yale in the past. And I don't know if you're still working on that, perhaps. Is that correct or no?
No, I've shifted almost completely to melanoma now.
Switching
but
to
it
melanoma?
was a lot of fun.
Okay.
It was a lot of fun. We did gene gun therapy with rabbits.
Oh, is that fun. Right? Because I saw that in your past. I wasn't sure if that still continued on. Well, anyway, without further ado, she's going to talk to us about the war of melanoma and the incredible stuff she's done with registries. And so please take the floor. And by the way, you see how I'm dressed. Please forgive me if I get called away for Mohs surgery, which is what I do most of the time. Erin Mangold agreed kindly to handle the Q&A at the end. So without further ado, Dr. Leachman, thanks for your willingness to spend time with us today.
Yeah. So I'm trying to find out how to, let's see, somehow I need to be able to share. Are you guys seeing my screen at all?
We are currently seeing your screen. Yep, it's not loaded into the presenter view yet, though.
All right, let me see if I can. It says I'm screen sharing, but it's not letting me get into my, let me see if I can do it this way. There we go. Can you guys see it now?
That looks perfect. Yep.
All right, great. Well, first of all, I just want to say I've had a very long-standing relationship with Mark, and we hit it off way early on in my career. And I really feel fortunate to be able to work with Erin and Colin. They're both fabulous, and I think I met Erin when he was just sort of right into either the end of his residency or fellowship. I can't even remember, but I feel really, really pleased to be able to have a good relationship with a lot of members of your team. And you have a great team, a really great team there. So thanks for having me. I guess I'm going to talk to you today a little bit about an experiment that's going on in Oregon. And there aren't very many public health experiments that have been done to try to show what education can do with respect to prevention of cancer. And so it's a pretty unique experiment that's going on, and I hope you enjoy hearing about it. So conflicts of interest, these are all of my conflicts, but I don't think I'm going to talk about any of these, with the potential exception of SCLIP at the very end, which is a clip-on dermatoscope that one of the faculty members in my department developed, but we don't have any, there's no monetary relationship between our department and them. And then the learning objectives, I think that Colin flipped through those pretty quickly, but I think basically I want you guys to understand the relationship between risk stratification and skin cancer screening, what increased the awareness of pitfalls, understanding baseline knowledge, attitudes, and reported self-screening behaviors in 3 Western states. That would be Oregon, Washington, and Utah. And then hopefully this will identify, it will bridge some of the practice gaps that we have with respect to melanoma and early detection. So just quickly, I think a lot of you guys probably already are aware of these statistics, but this is the rate of new melanomas by age group, all races, ethnicities, SEER data, as it climbs as people age. And then this is another graph that sort of shows some of the main features of melanoma these days, which I think is a really interesting one to look at, because it shows that, for example, here we have in the white population, we have more males than females. So this is, on this side is the males, and on this side is the females. And you can see that in that case, there's many more males than there are females. Well, not many, but there's more. And then you can start to see the distribution, which is consistent whether you're in the male or female category, in other ethnic groups: Black, Native American, Indian, Alaska Native, Asian Pacific Islander, and Hispanic. And what I think is really interesting about that is these are primarily not, they're not the classic photo-induced melanomas. And what's also interesting is there's not as great of a predilection for men over women as there are in the cutaneous melanomas. And I don't think any of us really completely understand that, but I think it may be something that's important down the line. This is just to show sort of the age-adjusted invasive cancer rates. And I think you can see Arizona's here. Interestingly, back in 2014, there were less melanomas in Arizona relative than in 2018. And in fact, here are the counties that had the highest incidence. Do you say it Yavapai? Is that how you say it? I don't know. And Maricopa and Kena.
Yavapai.
And then Yavapai. And then with respect to death, your highest death rate is in Mojave County. So in Arizona, 11,878 new cases between 2015 and 2019, and 1,005 people who died of melanoma of the skin. So that's your incidence and death rate. And if you look, here is a reflection of the change in melanoma incidence. And I think you can find Arizona right here up at the top. And I want to say that it's not quite as bad as it looks, though. And I'll call out something that probably everyone in that room back there knows, which is that there was a paper written that showed that there had been massive underreporting of melanoma in Arizona. And so this increase is likely not a true increase. It's actually a moving towards the truth of what the baseline values were, because it had previously been unreported. So it'll be nice to go from here forward to see how things continue to go in Arizona. And then this is just this makes a point that I want to share very dramatically. This is the stage distribution of all new melanomas. And you can see that most melanomas are identified in the localized stage, almost 80%, and much fewer at the regional lymph node stage, and then even less at the distant metastasis stage. And one of the reasons that that's so important is this next one, which shows the relative 5-year survival in each of those stages. So these are the latest numbers that we can get from 2014 to 2018 that are out. But what you can see is that if you catch in the localized stage, and this includes all the stage 2s, including stage 2Cs, which are bad, but because there are so many more of the early ones, the survival rate is 98% for the localized, 69% for regional, and 31.4% for distant. And the point here is that if we can move people from the category of distant over to localized, there's a good chance that we'll be able to really improve survival quite a bit in that population. So before I go on, I know one of the big things that has been a major controversy or discussion point within the academy recently is about overdiagnosis. And I just wanted to spend just a little bit of time about overdiagnosis. So just to get everybody, in case they're not on the same page of what the definition of overdiagnosis is, it is when it's truly diagnosed as a melanoma. And any pathologist would look at it under the microscope and say, yes, this looks like a melanoma. This is a clear-cut melanoma, but it didn't have lethal potential, either because it wasn't at a point where it was able to spread yet, or because the person passed away before it gained that potential to kill. And so what I would like to talk a minute about is how is this process, or how is this problem of overdiagnosis related to skin cancer screening? And I think to do that, what's really important is to think about a bigger picture than just overdiagnosis, because overdiagnosis is only one component of what you're doing when you're screening. So just like with any screening process anywhere, you have true positives and you have false positives. True positives result in a better outcome. You've actually identified a melanoma and you have the person take it out and they get it out before it's lethal. Great. False positive is when you think you've got a melanoma, you believe by screening that you've got it, and it really wasn't a melanoma. It was a false positive. So it's unnecessary biopsying and excision, potentially, if the false positive was corroborated by the pathology, and obvious psychological stress if you get that false positive. But that's not the only thing, right? You also have true negatives, which is also going to reduce the psychological stress, and false negatives, which lead to a missed or a delayed diagnosis and possible death from missing that. And finally, you end up with this overdiagnosis category, which represents unnecessary biopsies and excisions and psychological stress. But what's oftentimes not discussed as openly is failed diagnosis. If you decide not to do screening, you're not going to catch it, and that also misses and leads to delayed diagnosis and possible death. So I think what I'm trying to show here is this full spectrum of what happens when you're doing a screening that can lead to really positive outcomes or to negative outcomes. And at the end of the day, what we really need to understand well to be able to tell whether a screening program on balance is good or bad, is more beneficial than harmful, is you have to know what the rates of each of these independent little factors are. And it matters a lot. And the problem is we don't know that. We do not have the data on all of these areas, including overdiagnosis. So the second thing that I think is worth talking about just a minute, and I love it if you guys think about questions, we can bring that up. I'll try to go through the talk fast enough that we can maybe have a little time to have a conversation about any of these things that you want to talk about too. I think it's something important in our field to be having good discourse around. So as we know, we have different populations in melanoma, and so one of the ideas is that perhaps you can maximize the benefit that you have to screening a population if you risk stratify the population so that there's a higher possibility that you're catching a true melanoma and less possibility that you're getting either overdiagnosed melanomas or false positives. So you have a general population, moderate risk, high risk, and ultra high risk. And you have groups that are particularly positioned to be able to take care of them. You've got the melanoma specialists for the ultra high, dermatologists can go in, and these groups overlap, obviously, but high risk populations that need to be seen by dermatologists, moderate to lower risk populations that might benefit from screening by PCPs and some general dermatologists. But what do you do about this general population? We don't have enough people, even if you include all the PCPs, to screen the general population in person. And so how do you do that? And I think what you're going to see is one of our ideas is that we combine all of this together in our program, but we emphasize in terms of the general population, self-screening, right, and education. And so one of the things I will just mention too is, and Erin and I are on sort of these complementary AAD committees, and our committee is in charge of these public skin screenings, the AAD sponsored ones, and we've really been working hard in collaboration to try to figure out how could you, in an AAD public skin screening, start to try to stratify the groups so that you're pushing us towards catching more lethal melanomas. And that's a topic of hot conversation that everyone's going to hear about. It's going to be coming out in the next year or so. And the ultimate goal in this is, how do we best use our limited human resources and monetary resources to do the most good that we can with respect to stopping deaths due to melanoma and morbidity due to melanoma. So that's the why. Public health and melanoma prevention. Why? Well, why in Oregon too? Melanoma rates in Oregon are unexpectedly high, given the climate. You would think it wouldn't be so high, but it is. It's been, when I got there, it was the third highest state in the country. It's now moved down to about 15th, I think was the last, which is really, really great. We're excited about that, but that makes it a reasonable model state. It's about the same size as Schleswig-Holstein, which is where one of the early detection experiments was done in Germany. Melanoma itself is readily detectable, and it's readily detectable. Most melanomas are caught by the patient or a spouse or friend, loved one. In fact, up to about 70% when you combine those categories are detected by the patient themselves or their family and friends. Now that leads us to think, well, then education may actually work. It may have a chance to work. But what's real important, I think, is that there is no direct evidence, none, that a melanoma early detection and campaign or program leads to improved survival. The Schleswig-Holstein, you could maybe argue a little bit, but it's been a lot of controversy around that. There's no really direct evidence that the detection campaign there or anywhere lead to improved survival, better prognosis, decreased cost, greater knowledge, or increased or improved self-skin examination, right? So we have a lot of unknowns about what is the benefit of a public health program like I'm talking about. And that's why we wanted to do this experiment. So it is a statewide melanoma education experiment. And with all good experiments, you have a good hypothesis. And our hypothesis is that a broad statewide education program that teaches lay people and providers how to detect melanoma earlier will reduce death and costs. So obviously, our first outcome is death, but it's not just death. We can look in the cancer registry and we can see incidence of mortality, stage at diagnosis, Breslow depth, prognostic factors, and then also cost outcome measures. What happened before and after the intervention. And so it's a simple experimental design. You have a 5-year program. You determine baseline death and costs. Then you do an interventional educational campaign that I can talk about in a minute. And then you repeat the death and the costs over that time. And you compare to see whether or not you've made a difference. And that's a fairly simple thing. But any of you in the audience, and I know a lot of you are critical thinkers, you're going to say, but what about causality? That doesn't prove causality, right? And that's true. It doesn't, because we need to know if we observe changes, are the observed changes unique to Oregon? Because that's where we're having the campaign. And are the observed changes due to the campaign itself or something else? And so one of the ways we've tried to get, you're never going to get with a large experiment like this, you're not going to get true causality, but we're going to try our best to get as much evidence as we can. And one of the ways to do that is to couple this with a pre and post test for the people that are before and after the intervention. And what we want to know is whether their knowledge, attitudes, and reported behaviors. So knowledge especially about risk factors, their attitudes about whether they would go in to be seen and whether they think that's helpful, and whether or not they are self-reporting that they are doing skin exams. And why are those the particular things we want to follow? It's because those have consistently been associated with people who are doing screening and prevention behaviors, not only in melanoma, but in other cancers as well. So the idea is that it's a good surrogate for telling us what our baseline is, and then determining whether or not we've moved that bar after the after the intervention. And so we're doing a baseline survey of our test state, which is Oregon, but we're also doing a baseline survey of our 2 control states, Washington and Utah. And the questions are Washington and Utah good control states? We don't know. What are the major gaps in knowledge, attitude, and behavior that would be targetable by the campaign that would really move the bar? And is there room to improve? Are we already so far educated that an additional education isn't going to make any difference? And so with those questions in mind, we went ahead and sent out our baseline survey. So our baseline knowledge, attitude, behavior survey went to 15,000 participants. And I think what you can see is this is Oregon and Washington, and over here is Utah. And we got almost 15% return, which is way higher than what's considered in a representative sampled population like this. 10% is considered good, and we exceeded that. So that's a really good, legitimate representation. But we also sent the population survey out to our registry. We have a melanoma registry, melanoma community registry, that is comprised of both melanoma patients, but friends, family, and all of that. We have almost 11,000, or a little over 11,000 in the registry now, and about 4,000 of those were melanoma participants. And we sent the questionnaire to them too, thinking about them as being the top of the most educated that you're going to get. People who have already had a melanoma, probably in the general lay population, they're probably the most educated you're going to get. And we, again, got a good sampling. And the idea is we want to see the current state of knowledge, attitudes, and beliefs in these 3 states, but also whether there's the potential to move on that if we intervene, where we should intervene. This is just kind of fun to show you. We incentivized each envelope, which we were recommended to do by the public health survey gurus, with $5 bills. So that's 15,000 $5 bills right there. And then I've never seen that many $5 bills. And this is 1 day's worth of mail coming in. Most people actually completed the surveys by mail rather than online, which was we'd hoped to save the data entry, but that was what it was. So we expected to confirm that the educational campaign would have an effect by comparing pre and post campaign results in Oregon to the control states that don't receive the campaign, and by assuring that the control states are valid comparators, that they're the same at baseline, and by association of the recognition of campaign efforts with knowledge, attitudes, and reported behaviors that we know are good surrogate markers of true behavior. So here's our baseline data, and I think you can see down here we've got Oregon in blue, Washington in green, Utah in red. And I think if you look at age, gender, education, race, language, income, marital status, insurance, and whether they're in an urban or rural community, you can see that there's a very, very similar in every category, but that in fact the categories that have non-statistical but interesting differences, like for example here in age, we know that Utah has the highest birth rate in the country, and sure enough, you have a higher number of younger people and a lower number of older people. And similarly, we know that there's more private insurance in Utah, which is what you see here, and more public insurance in Oregon and Washington, which is what you see here. So it looks very good, very consistent, and we can conclude that the relevant demographics of Oregon, Washington, and Utah are similar. And not only that, but we can also, I won't go through all of the data, but the actual knowledge, risk factors themselves, self-reported exams, and all of that was the same across all. There were no major differences across the 3 states, which means that the control states are valid comparators at baseline. But let's talk a little bit about what the data did show, which I think is exciting to see this. We looked at, we asked several questions, obviously, in the survey, and some of them are about risk factors like UV vulnerability, and the color of your hair is another risk factor we asked about. But we also asked specific knowledge questions to be able to categorize people in low, medium, or high level of knowledge. And we asked about their confidence, what their confidence would be in performing a self-skin exam, because both of these in the literature and beyond just melanoma are known to be associated with better compliance with self-skin exam, or with early detection behaviors, with trying to get people to do early detection prevention. And the same, the benefit in a self-skin exam as well. So what we have here in the blue, I think you can see, is the answers to the survey that we sent out to the general population, and in green are the population that was sent to the registry, to the melanoma patients. And then what you can see is that these numbers are actually the percentage of the people in these categories. So this would be the group in the population that reported no sunburn. 48% of those people reported doing a self-skin exam at any point in the last year. And so what you can see is that as people increase their level of risk, they also increase their frequency, their self-reported skin exam in the general population. But in the registry population, that's not so extreme, because they all know they should be doing a self-skin exam. So it's movable, right? And the same is true here. It's in reverse order, because the highest risk is here on top. But I think you can see again that the people who have higher risk factors in the general population are doing more self-skin exams than the people who are in the melanoma population. And then if you look here, what we see is that the two things that we know are very commonly associated with better compliance with early detection behaviors, knowledge and confidence, are associated in both populations with better self-skin exam performance, self-reported skin exam performance. So we can conclude from this data that the individuals in the population perform more self-skin exams if they have risk factors, while the individuals in the registry have high levels of self-skin exam regardless of risk factors, and that greater knowledge and greater confidence are both associated with better self-skin exam performance in both groups. So that's great. So now we've got that. But who should we do the intervention on? How should that go? And my point was, in order to know whether or not you're making a difference, you really have to try to target everyone. And so we want objective, quantitative, and qualitative and subjective measures, as many as we can get, as many metrics as possible that we can afford to get and collect. We want on all of the different populations. We want to specifically target the lay population. It's the lowest risk and the least interested, and embedded within that population is a really important skin service industry group, the massage therapists and hairdressers and tattoo artists and acupuncturists. All those people are licensed. We have about 50,000 of them in Oregon, and we're able to reach out to them because they're part of a licensed organization, so that we know how to get in contact with them. We also want to reach out to primary care providers, because if you identify melanomas in that population, the most likely place they're going to go first is to their primary care, but they have less training and less time for skin examination. So it's a different kind of outreach, but it's an educational outreach to help them deal with people who are at high risk, who are coming in that need an exam. And then we have dermatologists. I don't need to tell this audience has less access, and pigmented lesion experts, even less access and fewer in number. So the campaign that we're leading in Oregon educates lay people, patients, and providers to reach individuals from every one of these risk categories. So how are we doing it? So I'm going to go through this quickly, and then I'm going to give you some examples, but it's really centered. We're trying to get data on all of this accumulation of different experiments, but each one of these is a different experiment. So within the lay community, what are we doing? We're doing a mass media campaign across Oregon, social media, which obviously bleeds out to the rest of the country, but we're trying to keep it as much as possible to Oregon. We have the patient registry. We have a community outreach and engagement team that has gone out and talked to the different community leaders. We have a high school educational program. We've got licensed skin service people that I was talking about, the massage therapy and such like that. We have a curriculum that we've developed specifically in collaboration with Impact Melanoma, and this is part of what we worked on with Colin. I think had some of this information in it. That is how you teach a person who's a licensed skin services person to communicate, to see what they're worried about, but to not overextend their scope of practice. We have a mole mapper tracking app that we can recommend to people that they can use for themselves in their own hands, at their own home. And we have we do skin cancer screening events that we've performed. We've reached out specifically to the Indian Health Service, both in the high school program and for the skin screenings. And what about the PCPs? The PCPs, we've reached out to the Oregon Health Authority and the Oregon Medical Board so that we can reach them all and tell them about the program. We've got a visual identification curriculum that allows them to learn by seeing benign versus malignant lesions. We've got a PCP education toolkit, and in that toolkit, it includes video demos of how to do a quick screening in their clinic that's a reasonable time to be able to do it. We have a CME roadshow where I've gone and presented to over 700 of our 4,000 PCPs in the state. We've done another kind of video that does biopsy demos and has instruction on how to interpret path reports from the biopsies when they get them back. We've developed an electronic medical record risk factor intake that they can have their MAs or nurses do a risk factor intake to see whether or not that patient actually needs a skin exam or not. We've got e-consults available so that if they get stuck, they can come into a dermatologist's office electronically. We also have tons of patient education materials that they can give out electronically or in paper to their offices. We have additional electronic medical record smart phrases that allow them to document a really good skin exam and list differentials and actually then be able to bill for the services they've provided. We have both general and more expert dermatology, and we've been training in dermoscopy. We've got a roundtable, and that roundtable actually is extended to the PCPs as well. We've worked carefully with the Oregon Derm Society to get the word out. We've got e-visits that are established, SCLIP home dermoscopy, virtual visits, e-consults. And then for the really high risk patients, we've got genetic testing, total body imaging, serial digital dermoscopy, reflectance confocal now, gene expression profiling that we're doing, and optical coherence tomography. So if we look at, I don't have time to go through all these, and you've got to think about this is a accumulation of different things that are all going on that we cannot tell because we don't have the resources to tell exactly how much influence all of each one of these has on the overall outcome that I just told you about before. But what we do have is we can have data that shows how each one of these may be performing independently. So let's look at mass media. So this is our first campaign. We did a pilot Start Seeing Melanoma campaign, and this is one of the places where we went out with our community engagement studios. And I'm very sad to say that when we took this out there, we had worked so hard on this campaign. We thought all these images were just, wow, how could somebody not look at these images? But in fact, the rural community in Oregon thought this was about sex trafficking. They didn't understand what this was. It was horrible. We got horrible feedback, and so we had to change the whole thing. But what we did do is we looked at, during that pilot, we used everything in that pilot drove people to our website. And in the website, we had three major categories. We had whether or not, because we were thinking about it from their perspective. If they're coming, they either want to know how to do a skin exam. They either want to know how to do a skin exam. They want to know whether or not they've seen something that's dangerous, and they want to know what do you do if you do see something dangerous. And so it directs them to that website that has all of those things. But this is what we saw. So here's the website traffic, and as you see, we started it here in May of 2019. This is when the pilot was done, this pilot campaign. And we bumped up our number of people that went to the website quite a bit. We had 16.23 million impressions, and you can see that's, you know, fair statistics, but not as good as I wanted. I wanted them to be fabulous, and they were okay. Here's what we did. This is sort of tracking the time course where we did the social media, Instagram and Facebook, Spotify, Pandora, Oregon Live. We had billboards in Portland and outside of Portland. We had radio in Portland and outside of Portland. And you can see that none of these seem to specifically align with this bump that we had, except maybe this little area when we stopped radio, that you got this drop down here. So it suggested radio was interesting, but I was really excited about these little spikes. And it turns out that these spikes were from the Portland Mercury, which is an alternative newspaper in Portland. And that is not what I would have expected. That was a surprise to me, but I think it's really interesting. And so what we learned was that print and radio get people to the website better than, say, billboards and digital media. But it still doesn't tell us, just because it gets them to the website, doesn't mean it's the most reflective of a lasting effect to get them to screen their skin. Because the goal is to screen your skin, and if you see something, do something about it. So our new campaign, which is relatively hot off the press, is now simplified, easy, and it addresses one of those knowledge gaps that we identified in the questionnaire, which is that people didn't realize that a new or a different looking mole or a changing mole was really important as a red flag for melanoma. So we built a new campaign, and it's really unbranded. It does have one here on this one billboard, but we've unbranded it for the most part now, because what we're trying to do is get people to use it no matter whether they're at OHSU or not. And so the idea, melanoma stands out, check your skin, you could spot skin cancer. And there's a YouTube video. I encourage everybody to go to the YouTube video. They were going to charge us $25,000 for voice talent to do the YouTube video, and I did it. I just did it for free. So it's my voice, so I want you guys to listen to it, see what you think. Don't tell me if you think it's bad. Anyway, this is a website that I was telling you about, also branded with that. And then this is the PCP. This is what we're doing sort of with the PCPs. We've, like I said, got a video. It's a toolkit curriculum. So the PCPs can come in and they can decide what they want to learn and in what way, what kind of media they want to learn it from. So we've got screening video. We've got visual recognition with a lot of pictures. We've got biopsies. And we've got all of those sort of supplementary materials digitally and in paper, and by electronic medical record, and you do get CME credit for it. And we've done a pilot study that looks to see whether or not what happened. We've got 269 PCPs that did the pre-test, then they completed the toolkit, and then 181 did the post-test. So we've got good numbers for how they responded to that. We tried to do it 6 months later to see what kind of retention, but we didn't really get enough to be able to be analyzed. And so here's what we got. We've got, this is the % correct answers that we got pre and post. This is the correct benign lesions and the number of correct malignant lesions. And I think you can see you get pre-education improves post-education, and that's statistically significant. And here in confidence, pre-education goes way up in the post-education, and again, statistically significant. And then this is just showing what the, the actual answers to the tests that you can see for each individual in this particular category, pre-education and post-education, and on average got 4.6 more images correctly, and again, statistically significant. So now this is the PCP educational tool that's out being distributed statewide to all of our PCPs. And then we've got e-visits and e-consults. I just thought you guys might think this was interesting. We developed our e-visit program back in 2017 because I knew we might need them because we were planning on doing this. So we wanted to get our e-visits done really early on. And sure enough, when we launched our pilot, it bumped up quite a bit. But then we were really ready when COVID hit, and it really hit hard. And we actually had to reduce to lesions of concern only and stop all the rashes, and it's now back up on the way up again. And then these are our e-consults that have sort of had a steady increase up from our PCPs. And then finally, I'm not going to really, I know I'm kind of running late and I want to leave some time. Oops, I want to leave some time here, but we do have a really nice, for that really high risk patient, we've got a new skin imaging and technology center that is not only being used to provide clinical care for those extremely high risk patients, but we've also got a fellowship program in case anybody's interested in applying for the confocal fellowship. We've got that. We've got some primary research we're working on. We've got a new optical coherence tomography prototype that we're looking at. And we've got also, what's really nice about this is that people can come in either in person or virtually, and we're hoping that what we're going to be able to do by reaching out to underserved communities is to bring the level of care up really high for those very high risk patients. And so this is our timeline. We started in 2013. And we developed the registry and mole mapper and the screenings and awareness events in 2014 and 15. We did the federated states, e-visits, rural health outreach, all of that through 2016, 2018, developed that School of Public Health thing. In 2019, we did that pilot that I showed you, and then COVID hit. And so we had to stop everything. We had planned to really release the big program starting in 2020 and had to back off. But we did get a chance to do a lot of those analyses to help us refine where we sent, what we bought as far as marketing and why, and what our knowledge, what our new campaign was. And so now we did that intervention, but we've got our new intervention now that's going. It's actually going to run from January through August. And then we're going to repeat that survey that I showed you the results for so that we can compare pre and post survey. And then we're also going to repeat the depth and cost and knowledge and attitudes and behaviors at the end of the 5 years is the plan. And so that's about it. And I've got a lot of acknowledgments that I cannot do justice to all of the help that we've received in putting this together. It's just impossible to say thank you enough for all of the people who've really contributed in every aspect of what we've been doing, including people that have been working outside of the state to help me figure out how we eventually move this outside of Oregon. And ultimately, the biggest thanks goes to the patients. This is for a scar project that one of our residents did to see whether doing really, really nice photography of their scars had any impact on their self-image. And it was really great. We got quotes from them. And this is a quote: "Together we can eliminate melanoma as a cause of death." And I love that. So that's what we're shooting for. And thank you very much for listening. And I hope you've got some more questions and that I'm not too long. It's hard for me to see how long I've gone when I'm presenting. Oh, not much time, but maybe a little time.
Yeah, Sancy, that was fantastic. I guess I'll open up first to the group if they have any questions, and I have a couple of my own.
Sancy, Alex, Secretary Chair, great presentation, an amazing amount of work that you and the group have done over the last 7, 8 years. and a very comprehensive approach. One question that we often see, ask in the clinic is that patients, the knowledge doesn't always equate action. Have you or are you implementing in this whole universe of your activities efforts at looking at how to engage people, maybe emotionally? What is that part that we as scientists in general are not able to communicate with data to the public?
Yes, I love this question. It is so important because you can teach people, and I don't have a real good answer for you, but what we have been playing with a lot. We have a formal collaboration. One of the collaborators on that acknowledgement slide is with the University of Oregon. They have a communications department. We're collaborating with the chair of the communications department and the head of one of their basic scientists within the health promotions group. And we have run so many social media ads looking at a variety of different aspects, like what you talked about. So for example, one of them is whether or not it's more motivating to stimulate somebody to look out for themselves by screening or to look out for their partner by screening. And so we did all kinds of really fun manipulations around, you know, if you put a picture up that's got one person in it, or a picture that's got two people in it, and what kind of people. Is it a mother-daughter? You know, one of the pictures was a wedding. The daughter was in a wedding dress and the mother saw the melanoma there. We've done all kinds of things. So fear-based. We've got great surgery photos from Mo's, for example, that, you know, are scary, right? We've done the things that are sort of, you know, guilt things. We've tried everything, self-efficacy. We've done, you know, all of those different things with a strategy to try to figure that out. And again, the problem is that at the end of the day, when you don't have enough resources to follow people, I mean, there's no way that you could do that experiment where you actually did the intervention and then watched each person and went home to see if they did their exam, right? So we don't have a way of really knowing whether you've got them to act, right? The best you've got are these surrogate reports of whether they are acting and whether they know enough and all that. So I think it's a great question, and until we figure it out, you know, I don't know, but I do believe, I guess the one thing I will leave you with, that what I do believe, I believe in power to the people. I just believe it. I'm a populist, I guess. I don't know. But I believe that people, when you teach them enough, right, when they understand that something is in their best interest, I think most people will self-direct towards acting and behaving in their own best interest. And so I think that's the trick. That's the trick, right? That's why tanning doesn't work very well, because people believe it's in their best interest to be more attractive, and they believe it's more attractive to be tan. They don't really, until you get to them and say that, no, it's in your best, you know, anyway.
Yeah.
That's all I got.
Thank you.
Other questions?
No, I just like to compliment you, Sancy, since I remember having discussions with you back in your days at University of Utah, and then what you've been able to do up in Portland, and really for all of Oregon and, you know, the Northwest, hopefully. And we'll see if this, you know, can be translated to throughout the U.S. And as you know, I mean, between you and what Peter Sawyer has done for that little continent of Australia, I think these are going to be the ways we're going to need to be heading. But I think it's outstanding, and I really appreciate your presentation.
Well, thanks. I think, you know, the whole point is that if we can get some data, I think it may be that we'll finally be able, if you think about it, why don't we promote, why don't we spend money, why don't insurance companies spend money on prevention like they should? Well, it's because they don't have hard data that shows that it's actually cost effective. And so if we can get that kind of data, and if we can get it to work for melanoma, then it's probably extendable. It's a great template for other preventable diseases, not even just cancer, any preventable disease, obesity, you know, diabetes, heart disease, you know. I mean, I think we could think about how do you take this further, right?
Have you mentioned that to Phil? Is he on board with that?
Oh, you know, we aren't allowed to talk to Phil until Phil. He's.
But I think I agree with you though, and I wouldn't be surprised if he's sort of been thinking like that as well.
Yep.
Sancy, I have one question for everybody who's on. One thing that I'm always kind of struck about, and it seems like anybody who's doing, you know, more and more machine learning is getting into the idea of not just identifying at-risk tumors, but being able to utilize deep learning to identify those at risk, meaning for squamous cell carcinoma, which is, you know, a non-seared, you know, non-indexed cancer, to indexed cancers. And there's a lot of the community that is looking at, you know, how can we leverage this amazing structure you guys have built to start to do more federated learning across data systems and health systems and ways to do it more efficiently. And not saying you guys did it inefficiently, but is there going to be a war on melanoma set up in every state? I mean, would be ideal, but ultimately the dollars and cents will be difficult. Are you guys looking at even, machine learning models with your own patients and your EHR of how you can start to learn from their primary care notes or other documentation that allows them to be identified as at-risk individuals?
Yeah, I think that's a really, really important point, Aaron, and we're not quite there yet. I mean, I think what we're trying to do, this is a hypothesis for me. I don't know if we're going to, I don't know if we're going to find anything, right? I mean, we don't know. We may not get to enough people. I mean, even if it's effective, we may not get to enough of them to make an effect, right? Because it's really hard to get to everybody. So I hesitate to do a lot of that sort of work. With the place where we're doing a lot of machine learning and AI is more in the individual image recognition and looking at confocal and how you map it and things like that. That's I think until we find out if it works. And if we find out that it works, I think we're going to have some definite telltale signs about what aspect of the campaign was the most successful. We've got enough of these readouts about how successful each one is, and we'll be able to see the cumulative effect that it has. And I think between the two, we're going to be able to see what is the most cost-effective strategy. And then I think that's when you start to say, well, okay. But I think it's a great idea. And I don't know if you guys have been doing a lot of that in Arizona at Mayo or not. But if you guys are starting to go down that path and you've got some, ideas about how to really do that, maybe we should talk about how to start thinking about it now, even though we're not actually putting anything into place. It might change how we analyze the data even, or how we prioritize the kind of data, So I would be open to hearing anything that you've got with respect to thoughts along those lines. That would be great. It'd be great.
Yep, I'll follow up with you on that. Thanks.
Good.
Great. Well, if there's no other questions, thank you so much, Sancy. It was really fantastic.
Thanks for listening. I really appreciate it.